Welcome to the POPMA Study Club, the Oral Pathology Stalwart series. And today we have our special guest, Dr. Dinesh Daftari sir. Dr. Daftari sir needs no introduction because he is a renowned figure in the field of oral pathology and cancer research. His pioneering work in oral cancer and pre-cancer studies has earned him recognition as one of the most influential contributors to the discipline. Dr. Daftari sir worked extensively with Professor Pindborg, a global authority in oral cancer research at Copenhagen, Denmark. Over his illustrious career, he has held key positions including Professor of Oral Pathology at the prestigious Nair Hospital Dental College and Honorary Oral Pathologist at the Basic Dental Research Unit, Tata Institute of Fundamental Research, Mumbai. Then it was Bombay. So the key contributions to cancer research, sir has conducted groundbreaking epidemiologic, histologic, and interventional studies on oral pre-cancer and cancer in rural area, which is the topic today. And sir has specialized in areas such as flow cytometry, nutrition, oncogenes, contributing to deeper understanding of oral carcinogenesis. His efforts were recognized by WHO Collaborating Center for the Prevention of Oral Cancer. He received continuous support from the National Institute of Health, United States since 1966 for his innovative studies in cancer research. His academic engagements, he was invited by the Medical Council, Research Council of South Africa as a visiting professor, reflecting his international recognition. He has also served as an expert panel member for Indian Council of Medical Research, shaping policies and advancing the field. And he has delivered numerous lectures and keynote addresses at national and international forum, sharing his expertise in oral pathology and cancer prevention. Pertaining to the publication, sir has authored over 50 influential research publications which have significantly shaped the understanding of oral cancer and pathology. He has co-edited the acclaimed book Oral Diseases in the Tropics, along with Dr. S.R. Prabhu, Dr. David Wilson, and Dr. Neville W. Johnson. Regarding the awards and recognition, sir has received the prestigious Dr. R. Ahmed Award, which is the highest academic honor from the Indian Dental Association in 1992 for his exceptional contributions to the field. He was also honored by the International Association of Oral Pathology and the Indian Academy of Oral Pathology for his impactful work and leadership in advancing oral pathology. Sir maintains a private dental and oral pathology practice in Mumbai since 1960. And he combines his research-driven knowledge and clinical expertise to provide exceptional care to his patients, bridging the gap between academic insights and practical application. To conclude or to carry on the legacy, Dr. Daftari sir's lifelong dedication to oral pathology, cancer research, and education has left an indelible mark on the profession. His pioneering research on the relationship between tobacco use and oral cancer has informed public health initiatives worldwide. As a mentor, researcher, and clinician, he has inspired countless oral pathologists and researchers globally. His legacy as a living legend continues to influence and guide the future of oral pathology. I welcome you, sir, with profound respect, and we are lucky enough that you are with us and you will share the journey of oral cancer and oral pre-cancer, which which is accessible to us nowadays with very less of effort because you have worked for that. So I request sir to deliver his lecture and continue for that. And again, a warm welcome to you, sir.
Yeah. Thank you, Dr. Nagpal. The first question is, am I audible?
Yes, you are audible, sir.
And you gave me a fantastic introduction. You only could have said one or two sentences for me to get into the picture that I've been working on this journey on oral precancer. I'm speaking to the audience at large, and I'm happy to be with you all this afternoon. And that The subject was in oral precancer. So I was going to concentrate only on the oral precancer because the oral precancer is the subject of relevance and importance simply because you can't deny the fact that we have a highest number of oral cancers in our country, and precancer is one way of dealing with it. But because precancer also has a lot of overtones with social, psychological, medical, scientific, political, and so forth, and philosophical. So these overtones could have been covered in a little detailed manner if I were to speak only on precancer. But Dr. Nagpal's suggestion was that I should be able to brief out the clinical history of our journey on oral precancer and what brought us to the relevance of oral precancer in this field of oral pathology. And I think he has a good suggestion, so I try and as brief as possible on that part of the game. But let's begin at the beginning. After graduation, always the question would come up, why did I get into the oral precancer story? After the graduation, way back from Nair, like 1963 around, we were working for some of the academic work in oral cavity. And one of the main things that attracted the attention was that those days, Tata Memorial Hospital, the senior professional doctors like Paymaster Jasawala, the serious name to reckon with, but casually or anecdotally making an observation that whenever they treat oral cancer, they had a feeling that they had seen these cases before preceded by a white lesion. But beyond that, no other observations were made. And that is why they felt the oral cancer could have beginning with some other lesion. That was an observation. And second thing, my colleague, a senior person, Dr. Fali Mehta, a great dental surgeon, a great person with an academic bent of mind. And he was a prosthodontist, but we were together and he was attached to the Bombay police. So we were working on the policemen because that was a captive population whom we can follow. And that is what we had been doing it before we started working on any other active work. So we were following the policemen, and during that period of time, as the chance would have it, like as I would say in my lectures, chance comes to prepared mind. We were possibly wanting to do the thing. We were destined to do the precancer study, and Professor Pinbock came in India, a giant of a person in the field of oral precancer cancer. His contribution is legendary, and he was working on this precancer scene in Danish hospitals. It was a hospital-based studies. I came into contact with him and we clicked with each other, with myself, Dr. Fali Mehta and others. And we felt that this kind of work that we were doing in Bombay Policemen can be done at a larger level to get a correct story on oral precancer. And we wanted to have a base. Dr. Fali Mehta was also connected with Tata Institute Fundamental Research. And therefore, one felt it whether we could collect the base at Nair or TIFR or so forth. And of course, the result by we were doing this work was this particular sentence that you are seeing it here. The dominance of oral cancer is a national problem prompted the study of oral precancer cancer. Now, significantly, as I said before, this statement is very true, or maybe more true today than then. And you can see that I'll just bring it out. This is what the ISCR reports of 2024. You can look at this cancer, look at these, you can figures and you realize it. We had started the journey in 65 and 2024, these are the figures. Earlier, also in 1933, the British Parliament had discussed the issue of oral cancer with an observation from Travancore. And in 1925, Gandhiji used to write observations on many simple topics. And in 1925, in Young India, he also mentioned passingly a reference that BD and tobacco is bad for the health. So if you look at the magnitude of the problem that existed in 1965, provoked us to do something serious about it. And as a dental professional, when we see the mouth regularly, it was quite evident. And with Professor Pinbock's initiative and so forth, we thought, okay, we are on the right track. So this is the Tata Institute of Fundamental Research. We were to apply for our research grant to NIH USA. And here we have Homi Bhabha and Dr. Fali Mehta. I don't need to say anything about Homi Bhabha because I think he's a legendary, is a figure by itself. But this was an institute, Tata Institute for Fundamental Research, which has been a cradle for various researches that is happening, the evidence that you see in India today, right from ISRO and so many other things. Now, in this particular base, they got nothing to do with the dentistry or the health. It was Basic Center for Nuclear Physics, Mathematics, and so forth. So I was interviewed by Dr. Homi Bhabha, and we interview lasted for more than 2 hours, in which he figured out himself that he was convinced about it. Okay, we have a right things to do simply because oral cancer is a serious problem in the country, and our contribution would make a difference to the healthcare of the country. With that understanding, the visionary in him allowed us to start working at TIFR or gave us a base. And the journey started. And you had Fali Mehta there and Dr. Professor Pinbock. These two stalwarts were with us all the time, and the journey started at that stage. We applied this research grant at that stage, and you can imagine the NIH, which was there with us, we applied initially for 3 years, and the grant continued for 30 more years because it kept on it kept on getting renewed simply because we were able to do what was expected of us. And this international academic partnership and the results that came off were really benevolent for both us and USA also. The USA tobacco policy also to a certain extent got modified by our findings, and the person who helped us all the way through was a good friend, Professor James Hamner, who was a liaison officer with us from NIH, but himself a brilliant guy. And honestly speaking, the team of Hamner, Professor Pinbock, Dr. Mehta, ourselves, became a kind of a unit that successfully carried this journey far for 30 plus years. So this is the background on which we started on oral precancer. Now, if you look at it, we were wanting to do the study not at a hospital base. It had to be done in the rural areas of India, because if you look at from India, from Mizoram down to Kerala and all that places, if you want to catalog these tobacco habits or any chewing habit, it will go more than 100 or plus. These are 32 habits which we have put, which I am seeing in the slide. It's a panorama of pastime. People indulge in the habit like every one of us have some habits attached to us, which is fair and fine. But not knowing the consequences of what that habit can lead to is not fine. So this was the study that we wanted to do in rural areas without any intervention. And we were wanting to follow, first of all, wanted to find out what type of lesions are occurring. So accordingly, we started this work in 5 states in India, and Bihar, Gujarat, Srikakulam, Srikakulam, Maharashtra, Kerala. And this was the initial part of the study to understand the habit relation with the lesion. And for the first time, there have been all the time oral cancer registries, but for the first time ever, we put the oral precancer registry, knowing well that there is a preceding lesion happening before the oral cancer. With that kind of an observation, it was quite relevant that to have a precancer registry rather than cancer registry. And if you look at the needle of suspicion that we wrote during that time, you had pre-leukoplakia. We had studied that word before leukoplakia, and then you can go down the drain and go down the line. You will find the submucous fibrosis comes little in the lower part of the category. And plus, we had this syphilis to be and siderophrenic dysphagia, which you see in Western countries, a part of the important consideration for cancer. So this was the needle of suspicion for which we calibrated our team of doctors and in the field. That took a little longer time, but we saw that everybody was calibrated to the clinical finding so that there is no error, no judgmental mistakes and so forth. But if you all know, the patterns have changed over the last 50 years. I mean, everybody knows, all the oral pathologists who are involved in the subject of academics or in the subject of cancer or precancer, one can easily find out that these are the kind of lesions that one sees in the mouth. You may see it this way, or you may see it similarly at that stage, or of course, you can get at the stage where the perforation happens and you get the oral cancer. I'm just telling you the chronology of it to the extent of why it is so relevant for you to understand that examination of the oral cavity assumes very significant in view of the high cancer rates in our country. Now, I'm just showing you clinical example of few habits without going into details of it. Here you have a Maharashtrian lady using Mishri, just up there. So here she applies Mishri for cleaning of the tooth. And you can see that there's a regular habit without her realizing what can happen. And if you look at this part, it can be this or it can become like that. Or you can go into that stage. These are some of the pictures which would just to let you know why we were doing this kind of a study. And these are the habits that we studied. And in Gujarat, we saw this gentleman smoking hookli. Now, this was unreported so far, but you can see the tranquility on the face. You can imagine the importance of a habit. It gives a peace of mind. We all have some habits possibly, and I called it a pipeful meditation. But most of us don't realize that the consequences of a habit that you choose at the stage without realizing what can lead to. And here, this meditation or pipeful meditation, Bhavnagar, is a hot clay pipe, and you can see a lesion in both upper and lower lip. And it can happen. Fortunately, the final results were such that the lesions in this Gujarat area, because the habits were not so well. And here, of course, we all know this one, this butterfly effect because of a smoking bidi. You get all over the corner, the butterfly effect. It can affect the palate too. This is one of the most common habits that you find it in this country, and there's a bidi. So these are the examples of few habits which are common. In Shikakulam, this is a habit that you see of a reverse chutta smoking. I'll just give you briefly an understanding of why such habits come into picture. In any field of study, anywhere in the world, whenever you're doing it, the cultural considerations and the traditional aspect of the life allows you to understand what sort of things people do and why they do it. Now here, for you to understand why somebody should smoke reverse, because these ladies were wanting to smoke, they are fisher folk, their husbands were fishermen, and they would be going away in the boat. But like a typical vanity, they don't want their husband to know they are smoking, so they would not have lighted end of the chutta, or what we in the Andhra we call it adapuga, to be seen. So they had to smoke reverse. Another consideration was this: okay, coastal Andhra has a very gusty winds. So if you were to smoke like that, it will get extinguished. And thirdly, if you look at it, these are the habits that came out while we were working on the area, when talking to the people. They wanted their house to be clean. They did not mind their mouth to be unclean by putting tobacco ashes in the floor of the mouth. But they never wanted their mouth to be, the home to be dirty and ash to fall there. So all of them, plus there are little more other considerations also. But then if they were to smoke this way, while they were working, they had to get the chutta or adapuga. The vendor would give this adapuga to them, but she is working, so she will ask her daughter to get the chutta. When the vendor gives the chutta, vendor also lights the chutta and gives it to the daughter. Daughter also realizes that she cannot carry the chutta directly to the mother because it will get extinguished. So she starts smoking reverse from the age of 7. And the habit continues, is mainly in the Andhra, in Srikakulam, mainly is confined to the ladies. And we have seen the cancers happening on the palate and on the tongue by the age of 25, 30 or so forth. But this is the background as to how the habits gain ground into the population. So therefore, I said, okay, whenever you want to do any studies related to the habits associated lesion, it's very important for us to understand how did that habit gain ground. And when a habit becomes a necessity, then generally the consequences are to be followed and things can go wrong. It is at the stage of this that you have to make them aware of it and things can change. And here's a good time, cheers. And you can see the palatal changes. We took 6 weeks or 6 months around because everybody knew only about Nicotina palleti from the Western books. Nobody could really know what kind of a changes would happen in the palate when you smoke reverse. It was a kind of a understanding or brought out that we have had to do this work a little more effectively to see that we were able to describe the palatal changes because there were multicolored changes all in a different manner and that to be classified eventually in our data. So it took a little while for us and we succeeded in classifying these palatal changes in reverse smoker. It's important for us to understand how a chutta habit creates a pathology which is widely different from a known pathology for BD smoker or a cigarette smoker. Now, roughly having given you that consideration, I'm putting some results from 30 years of work over 200,000 population in 7 Indian states and rural areas. We have published a large number of papers. Dr. Nakpal mentioned 50, but it's far more. And many other papers were published earlier days. And this is I want you to see the last book, Tobacco-Related Oral Mucosal in India. This book is not available at this moment, but we had 287 color prints explaining exactly about a precancer lesion. It's a really nice book. And because of WHO grant, we were able to sell this book for 75 rupees only. And the last one is that this is for dentists also. But I mean, these are there. We have done it enough for see that the profession gets the best of it. What did we learn the lesson? As you said, we wanted to do the pre-cancer registry, so we learned some lessons. We were studying at this moment, whatever we saw was the life history of leukoplegia. The other thing, what we saw, leukodema, pre-leukoplegia, has not been given any importance in this presentation because it was not relevant. But we have done all these things, recorded and published papers. So here, when you want to follow a white lesion, what do you follow? You have to follow the history, life history. And imagine these were under no intervention methods of advice or counseling to give up the habits. So here you can see that either the leukoplegia will stay as leukoplegia or it can change into cancer as indicated by observation by Tata Memorial Hospital people, or it can go away. Or once the leukoplegia disappears, it can recur. This is the phase 2 part of the result that I'm giving you in this presentation at this moment. It was published as a big long paper in 1985 in Community Dentistry Epidemiology, which is a classic paper of a first-time follow-up of a 50,000 individuals in house-to-house survey for 10 years, with all the details and data, including incidence rates and so forth. What I'm trying to say here is only just some information which is relevant to this presentation. And you can here see the cancer coming out in a leukoplegic lesion. You can see in the center, which shows that the lesion itself is getting transformed into malignancy. It makes it very clear that the origin of the cancer was from the same lesion, which establishes the fact that a lesion that is happening because of the habit can lead to a cancer formation. Here is one of the very good clinical case of observation of a lesion transforming itself into a cancer. And these are some of the few pictures which you can see from Kerala study. Here you find a leukoplegia in a buccal mucosa getting into a cancer. This is nodular leukoplegia. And at the same time, and most of them should be surprised to know that in spite of the continuation of the habits, about 20 to 40% of the leukoplasias or the lesion regressed. There was no intervention. It was a natural, spontaneous regression happening upon lesion. That's quite important for somebody to realize the fact that all precancer, of course, doesn't go into cancer. That's a well-known fact. But there's a certain amount of a regularly happening into the mouth, which does not allow leukoplakia to go beyond. As a matter of leukoplakia disappears. There was some recurrence, but the fact of the matter is that you must understand a regression can happen. So if I were to put it in a nutshell, this finding incidence of precancer lesion almost exclusively among people with tobacco habits, carcinomas exclusively among tobacco habituals, and all carcinomas originated from precancer lesion. So if you look at from the prevention point of view, there's a very definitive observation that you can come in, try to help the prevention of oral cancer when you have such findings coming in, because without tobacco, the cancer is not going to happen. Without precancer, the cancer may not happen because we never had a de novo cancer. Now, these were the findings in that paper. Then what happened? I put it in a simple language word so that we can, when you speak to the layman or lay and learned, even the dentist, it should be able to understand that fact very well. So here I've written very well that precancer is where tobacco is, cancer is where precancer is, and this is the kind of a truth conveyed in a manner that can appeal to the people who follow this work. I showed you a number of cases, the wide range from palatal cancer, buccal mucosa, there were tongue cancer and so forth, but it suffice to say that all the wide range of precancers all over the mouth would eventually lead to cancer. And this is just to let you have a figure to indicate that when the lesion is small, the treatment gain is big. You can see the gentleman on the left side, where you find that the commissure leukoplakia, which was nodular leukoplakia, excised and the person is fine. And here you find that on the right, this was a patient from Kerala, and we operated on him. And the treatment, the lesion is big, but treatment gain is near. And therefore, it just lets you again realize that fact that intervention at a stage earlier than a cancer can make a difference. I am not suggesting any mortality or mortality figures. Mortality is not left for us, but I'm sure morbidity can certainly be reduced. And this is the relevance and significance of finding a lesion which can be handled at an earlier stage. So, an example here, we made a statement rather, biorealistically, oral cancer is not an effectively targetable lesion. It's not, but the oral precancer is. So, in simple language, oral cancer is our limitation. But precancer is certainly requires to be followed it up in a big way. If you feel that you want to do certain things for this oral cancer malady, serious pathology of our country. So here the tipping point is a precancer where there is a possibility of your going reverse gear. Like a Holy Bible, precancer was, as far as we are concerned, there's a total clarity on the subject. And that's what I'm coming to you, because whatever the presentation that we are doing it at this stage, it is after logic, conviction, understanding, follow-up, and having done the job. So therefore, we are in a way able to make that statement that oral precancer is our scope and targetable lesion should be oral precancer. You have seen from the picture also, the worrying about fait accompli cancer is impotency in a way. And you can try to do whatever you wish, but hurrying on precancer is important where you have a chance and scope to do something about it for the patient. And to realization, that is our final objective, that we look after these people. I've given you same thing in a simple platform, that there is a reversibility at a precancer level, but there is no reversibility at a cancer level. There's a fait accompli. So we are effective for primary and secondary intervention at the level of precancer. That's a message, generally very ordinary message, but important message for us to intervene and help the issues on oral cancer. Here I'm bringing out another observation. I'm now talking only pre-cancer seen in relation to India. I'm not mentioning the pre-cancer story for anywhere in the world for any other cancer. And for that, this statement by John Bastakis on oral cancer, it's a book on oral cancer, I think written, published in New York by Jatin Shah from Sloan Kettering. If you read that sentence, that you realize that the intraoral squamous cell carcinoma is a relatively unfavorable prognosis with an overall 5-year survival rate of 35 to 50%. And he writes the survival rate has regrettably remained virtually unchanged over the past 3 decades. The statement is being made in 2003. And I've been going through the Minal Chaudhary of our, she has written a guest editorial, and she resonates with the same observation that nothing has changed. Who should be asked to bell the cat in such a situation? Is it natural or nobody's intervening in the matter? But you can see the serious problem of oral cancer that is happening here remains unchanged, and to my mind, or to whatever the science is available, pre-cancer can make a possible difference. And here you have Neil Johnson, again a good friend of ours who was involved with us in writing a book. The journey with oral pathology and pre-cancer has been, as far as I'm concerned, had a large number of good colleagues, good people, and enjoyed myself in this journey. With met very interesting and a very academic and brilliant people, good friends, all of them. And here you can see what Neil Johnson writes in the same book. If you read the second para, in high acidity area of the world, notably South Asia, the reverse is the case. Tobacco or nut chewing habit results in chronic lesion. The majority of oral cancer arises from such lesions. This carcinoma distinct to natural history, which is much less aggressive than carcinomas arising de novo in the West. In the western part in America, normally I see cancers in the floor of the mouth, posterior one side of the tongue. And many times it's de novo. Habits are not in the picture. And therefore I wrote here Rudyard Kipling, quoted Rudyard Kipling in a different matter, that twain shall never meet. These two different types of cancer shall never meet in true sense of the word. But if you have to have an oral cancer problem in this country, which is fair and fine, but having been given a cancer in the buccal mucosa, an easily accessible area for you to intervene, and having a, as Neil Johnson says, and we all say, the reverse, the level of pre-cancer, the reverse gear can be established. So from that angle, oral cancer happening in buccal mucosa allows you to certain basic advantage for you to be using that advantage for the benefit of the people at large and population at large. And I do believe that dentists who sees the mouth usually, not like other doctors who see casually, should be the first focal and nodal point to do something about it. And that might change the scenario for oral cancer in this country. As an oral pathologist, we have a proper understanding, and people in oral medicine also. So combined together, one can make a difference. But that is an observation. But cancer buccal mucosa and 90% of all the cancers in the mouth with the habits are squamous cell carcinoma. The location is mostly in the buccal mucosa, an easily accessible area, identifiable, doable, reproducible, and all that you can ask for. Now here, this is quite important for you to realize when you deal with the India, why it's important. India is such a huge country, so anything that happens in India gets a gigantic proportion. So for all practical purposes, India can consider to have a global leader in oral cancer. And you can see that there are some figures which I've written here. In today's days and time, India is talking about, our people are talking about that we have a younger population, and they call it a demographic dividend. And politically and economically, we are taking an advantage that India is now have a young population, which can be serious and which can be certainly a advantageous position for the country. But if this young population, if were to fall prey into the habits, then this can lead to a demographic disaster also. And I'm sure all of you, in a big way or a small way, know that these habits are not just going to go away. And you need to be doing something about it, because we have been given the understanding, we are given the knowledge, we are professional, we are privileged to do something about it. And we are supposed to be speaking on behalf of the people who can't speak. We are supposed to be looking after the people who can't look after themselves. So all that put together is quite relevant and important, that for us to understand this is another type of oral precancer awareness situation. So, and this is what I can follow it up with another slide. This slide was a few years back when we were in the USA or somewhere, and the Bill Gates, I saw that interview, and what he said very clearly, which makes you realize it, what everyone in the world is talking about, that India, you don't see oil, minerals, just people, and unleashed his potential. If you look at the far-reaching consequences of such statements coming out from a person who understands the economic, you realize that this statement has a lot of bearing for all of us. So here is the one that makes you feel that pre-cancer story can be taken to its logical conclusion in a normal healthcare measure. I'm sure you must have gone through the book. You might not have read but I've gone through Emperor of Melodies when it was published in USA. Had a chance to talk to him also. But you can see what he writes. Cancer today is defining a plague of our generation. And here I mention to you again that it has an overtone of medical, scientific, philosophical, and so forth. If you want to demystify this immortal illness, to eradicate this disease, one must always remember, okay, the simplest way of doing things is to either clinically, medically, by pre-cancer level, philosophically speaking, to get that important, the oral cancer is not important, but oral pre-cancer is important. And as far as the political overtone is concerned, I don't feel very comfortable of coming out with a product to ban the tobacco. Because people, it is our job to convey to the people, okay, tobacco is not required to live. As a matter of fact, you have to leave tobacco to live. And health is you and not government. And you may not want government to come into your private lives also. And suppose if it comes, you ban the tobacco, do you think that government of India can implement the law by any order situation? Most of the laws are not being followed or cannot be followed simply because it doesn't have that political will, it does not have the resources, manpower to implement any law, particular law like this of banning tobacco. And in a simple language, if I have to see, when I was in Maharashtra, in Wardha, which is the only pocket which has no prohibition, and there was suicide committed, the guy told me, the taxi driver, because there's a prohibition, and he said, Bandi mane barbadi. You create a feeling of a need. When you say nothing is available, you want it that way. I mean, it's all again a psychological overtone, but the fact of the matter is that oral cancer issue is our job to do it, and I don't think the government is in reality be part of this. We have to do it ourselves. And in that relation, I wrote a small publication of temporal role of tobacco. It's a time-associated role. Tobacco by itself doesn't cost too much immediately. So you have a time gap period between the cause and effect. There's a gestation, there's a time where inception of cancer to inspection by the clinician may take a decade. In simple language, you have been gifted the time by the nature for you to intervene if you wish to intervene. And that's the key thing in the life. Nature has been benign in that sense. It's not suddenly occurring. So far in this part of presentation, there has been no de novo cancer, but the cancer does occur, habits do occur. As I said before, the freedom of choice or freedom to choose the habit is at the time of a choice. And if you have created enough awareness in the population, the choice may be rightly taken. But having not understood the choice, they choose the habit, and it gradually unfolds into the consequences of cancer, on which neither the patient, neither you have a control. So looking at it from that angle, we can intervene at a level of precancer by level of social level, educational level, and at many other levels. So this is the another aspect of oral precancer that is relevant for us to understand. It's not just the clinical thing, but too many factors go in if you want a precancer story to be effective for you to do the job. Now, again, as SMF, you saw in the, it was a very low in the line, submucous fibrosis. It was an enigma. Though it came out in 1954 by some observation by Joshi and Squad, but truly nobody really knew about it, submucous fibrosis. In 1966, we noticed fibrosis, and in 2004, we wrote some paper which indicated that we gave submucous fibrosis a force to reckon with. And I'll tell you how it went. In Gujarat at 1966, we only had 16 cases of fibrosis, and they were all females sitting at home trying to use arecanut. That was one of the reasons I was there in South Africa also because of Wenwick, and I compliment Dr. George Hills, and I'm happy to see him around today. Brilliant, beautiful country. Had a most pleasurable, good time with in South Africa because of Wenwick and others. And this is God has made that country, is heaven on earth. And I definitely feel that I was fortunate that I could visit South Africa number and be there. So those Indian people who had gone there, the Indian ladies who had gone there during the earlier days of South Africa, they can never buy tobacco otherwise, unless if they want to go buy tobacco, somebody would be able, they have to tell somebody. They're only having areca nut. And at that stage, Professor Van Wyk showed 2 cases of cancer in a fibrosis, which he was written a paper on the subject. So first time there was a bit of an inkling that areca nut can be a carcinogen. But so far in India, and as far as I am concerned, I don't know what others, but fibrosis per se itself, I have not gone into a situation called malignancy. But you can see 1966, this was the position of fibrosis. We back in the same 1990, again we studied the thing, and you saw what happened. SMA was overwhelmingly man. 75% of patients were under the age of 35 years. You can imagine this MAVA came into the picture. MAVA was an unknown quantity till those time, and again that was introduced by whatever the reason may be, again an habit in a different form. And everybody in Bhavnagar who used to work in the diamond industry, what they call it hiragasu, they have to polish the diamond, they will keep chewing MAVA in their mouth. And that is how the MAVA brought this fibrosis into the forefront in that area, and you can see the figure in 1990. And the tragedy of the whole thing was that MAVA, another side effect of MAVA that came out openly was because all the gutters and sewer became choked because the plastic feeling of MAVA where it was started in the air would go down and choke the gutters. That's how the MAVA became a nuisance from that angle, and therefore they wanted to do something about MAVA. But you can see from 1966, which is an enigma, becomes a kind of a force to reckon with in 1990. And then you go further in 1998. We went into the same stadium, and in one of our dental clinic of Dr. Sinor, and you can see at that time we wrote, when we found that prevalence rate came to 3.2% and 164 cases of fibrosis were seen. And you can see that what we wrote there, I think it's published in Indian Journal of Medical Sciences. The Gupta was our senior author on that, and good statistician, good epidemiologist. And you can see what we wrote. This could lead to an increase in the incidence of oral cancer in the future. That was written in 1998. Today, if you go around anywhere in India, fibrosis is very common. Again, there are reasons why it happens. I don't know, I'm asking a simple question. Who will bear the cat? Are we supposed to be doing something about it? Or we just have to come out with kind of an observation of this kind? And this is the point. if you drive down from Kashmir to Kanyakumari, in all the pawn shops, you'll find the garlands of this thing hanging around. WHO gave us the position of collaborating center, and we did that work around. And because of our study in Maharashtra, they banned gutka. But then you know very well, a businessman is smarter than all of us put together. He started installing areca nut and tobacco together because tobacco is not banned. Tobacco comes under the national product at the central level. So you know how these things work out. So political overtones are something that I don't feel very comfortable with. So coming to this, cancer was rejuvenated. And you found that fibrosis became a force and the cancer got a new lease of life. And therefore, I wrote somewhere at that time when Manmohan Singh globalized the economy, we Gutkalized the country. And this is what Gutta has given a shot in the arm. And you find this cancer occurring all over the places. And it's a cause of the changing pattern. I made a conversation with these people at that time in Rajkot that there are very nice areas in India where small group of people still work very effectively and seriously on this subject of oral cancer or otherwise, whatever they are very conscious about the health. And he gave me this report from Rajkot, and you can see that that cancer tongue has been increasing over a period of time, which was never there recently, most of the time earlier. I'm just giving you one figure, one slide, one statistic, the malignant potential of oral precancer. You found the leukoplakia came down to 3,243. And here you find submucous fibrosis came to 397.3. Something, what do you call it? An underdog, you might call this in the language like that, came into the forefront like a derby horse and came second. And all this thing happened because submucous fibrosis came into picture late in the life, but with the increase of the habits, MAVAs and all that kind of a thing, it came as one of the leading contender for creating a situation of magnitude or increased numbers of oral cancer in our country. So how are these habits related in cultural consideration that can change the pattern of this country? I mean, these are just a play on the words, but it gets you the message that you chew now, cancer later. And cancer was a game changer. I mean, gutka was a game changer. And in a commercial language, chew now and cancer later. And business-wise, it's an ideal disease. You know why? In a commercial manner, that you buy one SMF and you get cancer also. So this is a kind of a putting it in a lighter tone. The oral submucous fibrosis can be expected to result eventually into oral cancer. So commercial is a viable purpose. There's a rags to riches story of all the gutka people. When I first came to South Africa in 1995, I might just mention to you, since Professor George is in the audience, that the gutka industry, pan masala, though in spite of the sanctions in South Africa, was more than 150 million US dollars. This at 1995. Today, it has gone beyond a certain, which I don't know. Nobody can figure out unless. But this is what the submucous fibrosis has done to our stage. But apart from this pre-cancer cancer study, what we studied was more important, that we followed the cases to figure it out other relevant clinical part of the game, which is unfortunately from my side, okay, whatever we did, there's never any reproduction of the similar study in a similar manner by people here in India. I don't know why. That's a lament that I have, that it could have been reproduced to reconfirm or rejected. That it's not a difficult study to follow, a clinical study of that kind, but somehow or other I did not find any reproduction of the similar studies happening. But you can see that in the earlier observation of regional clinical features, submucous fibrosis covers the entire mouth, but you can see the difference. In a different state, it happens in a different manner. Like you saw that in Pune, majority of the people eat areca nut, and therefore they swallow the areca nut, so posterior buccal mucosa gets more involved, And for that, esophagus also gets involved in some way. So higher involvement of soft palate, uveal and rectomolar area. But if you look at the habit that's there in Kerala, where areca nut is chewed with tobacco, so you have to spit out the tobacco. The result is that anterior part of the oral cavity gets affected, and you can see that major part of the buccal mucosa affected, tongue depopulated, shrunken, mobility impaired, because you bring the spit out or spat out and try to do it. And these are observations. Now, for that, I must give a compliment to our Kerala team, mainly Dr. Bhosle and Murthy, who are one of the finest clinicians and some of the finest academicians who involved themselves totally. And you can imagine clinically, when we are looking at the thing, I realized one point observation. If you are alert, then you can be aware of something happening in the mouth. And if you are get aware, then you can pay attention. And if you pay attention, then only the action can be taken. So these are the kind of a thing, observations, which were noted down in the remark column, so that we realize it, we prove it at a later stage. And majority of the time, these observations have made a difference in the clinical understanding of these cases. Now, this particular one also, fibrosis, has in that way makes a difference in the occurrence of the cancers. Here, the petechial hemorrhage, we never saw anywhere else except in Kerala, this petechial hemorrhage, though it was originally written by Joshi in 55. The more other important observation, we are shifting from pre-cancer to something different, but when we see the slide, when the biopsies are seen for us in the TIFR, when it comes to us, we look at Professor Pinball also was sitting with us many times. But otherwise, when we see the slide, we don't want to see the clinical picture. We just want to find out the histology. And we found that in 11 cases of fibrosis, the biopsy showed atrophy of the epithelium, which is a very typical fibrosis. But when you looked at the clinical picture, it was not fibrosis. And you only identify fibrosis clinically provided there is a fibrous band to be seen. Otherwise, you don't. So we saw the clinical picture afterwards, and it was a blanching, but not fibrosis. But we followed that 11 cases. Here is a blanching, and the histology was suggestive of fibrosis, but no fibrotic bands. Clinically, we were very definite. You only identify fibrosis if you feel the fibrotic bands. And we followed that 11 cases, the Kerala team, and we found that these cases eventually did become fibrosis. So that brings out another clinical pointer for us to realize it, that blanching can be precursor to fibrosis, like we had a pre-leukoplakia to leukoplakia. Yeah, I mentioned this. We mentioned this fact. Again, it brings out the point, in a study of this magnitude, everybody played its part. And honestly speaking, but for the people who were committed with passion, these things cannot be done. This journey has been very interesting, both from the point of view of satisfaction, for feeling that we have done something people have done with the passion and not necessarily only payment. So now I feel that we were at that stage where we need to be out in the clinical world, having understood that cancer is an issue, but we cannot afford to put it under the carpet. We need to do something about it. There's enough evidence, enough clarity in direction, and we define our own healthcare system. We need to read ourselves. Nobody else is want to come and get it done for ourselves. Because it's an Indian problem, and we need to talk about it from the Indian. I'm just suggesting that is our issues, and I think whatever the hurdles, or whatever the policy, or whatever the teaching, whatever it may be, we'll have to circumvent that somewhere or other effectively to try and find a solution. Because as I said before, thinking from a demographic point of view, people who indulge into this habit do not know what they are getting into. And that's why whenever we have learned this thing, we are supposed to be speaking for the people who can't speak. And we need to do it for population which cannot look after themselves. It's as simple as that. And I think we can do it it's not that difficult to treat because we are trained for it. Here again, another factor, though, as an oral pathology subject is becoming wide and very interesting, we're coming out with a lot of good papers, which I have seen it over a period of years in the publication. And basic research is becoming, which is a possibly a fundamental of science capital, and someday they will answer many questions that we are looking for, which we are right now we are unaware of. So the basic research is a value, is a continuous process, forms of science capital. But that basic research for the moment should be applicable to our study in cancer, which will help us to prevent oral cancer. So that is why I felt right now we need to have pre-cancer as a priority and not necessarily all the paper that we think about it. And because we have a very high expectation from some of these basic papers, and possibly they are going to least expected results because these results yet cannot be transformed into reality by using them for preventive programs on pre-cancer. So therefore, in a simple language, if I were to see, what is employed most complex investigative machinery we have written? Simplicity divinitas in a Latin way, the answer is that most of the publication can be cerebral. Simple answers are required for this kind of a situation in this country at this moment. But they are dealing with the population scattered all over the country in a rural area. Science has potential. Knowledge is power, provided it's operative. And right now, knowledge is required, but what we require right now is doing something. And as I told you before, if somebody could have followed it up and rejected and reconfirmed or accepted our study conclusion, then one would have been able to say something more. Today, what is happening? I mean, everybody knows what's happening with the cancer therapy. Escalating spiral of expenses has been in direct proportion to exasperating spiral of expectation. Most of the medical crowd, or most of us feel today's days of science and technology and doctors and all that thing, cure is possible. But if it doesn't happen, but by the time you realize it, you go through this escalating spiral of expenses, and then ultimately you lay down yourself into the expensive sick bed. And I'm only talking about oral cancer as of now. So mortality may not be under control, but morbidity, we can certainly try to understand that and do it. So that's why I mentioned this fact. The expectations are high. We have oceanic output papers, but it's not applicable. So I consider zero outcome from that angle. And I just mentioned this year, I had a total war on cancer in 1969. Oh, I'm sorry. I think I've taken time. I'll briefly finish, Dr. Nagpal. I'm sorry, I didn't realize it. Anyway, we have spent so much money on
No,
this.
go ahead, sir.
I'll finish in a few minutes, please. I'm sorry.
No, sir. No, it is such an interesting. Please take your time, sir. Please go ahead.
Anyway, you're giving me the liberty to do that. I thank you very much sitting there. We started the journey. Let me finish the journey now. So here, the total war on cancer, what he is talking about, Nixon, he felt, if I can put a man on the moon, America can, what is cancer? So therefore, it is 200 years of centenary celebration. He wanted America to gift America a cure for cancer. And therefore, he had what they call it total war on cancer. But even then, billions of dollars are still being given today in the cancer. But this is what total war on cancer came up by Nixon at that stage. And I don't know whether we have been able to sketch the sea of the cancer yet, because cancer is its own issue. But that was the thing that if America can put a man on the moon, cancer is not that important. I mean, he can take care of the cancer. That's why I just mentioned the thing. It's not the money. Right now, you require is a involvement. And I mentioned this fact, why it is so easy, because you can already do a biopsy and simple thing. We used to do biopsy in the field. Patient will go his way and I'll go my way. Not that we were not available, but most of the time nothing happened. Everybody was normal. And I did understand some cytological tentativeness. And the cytology or anything related to cytology doesn't work was histocytological differentiation of dysplasia was only 35%. So you will have to depend upon a good biopsy, and that's why punch biopsy is the gold standard. Anything else you do possibly will make you feel that you're not done enough. So here, that's why I made a statement, remains the sheet anchor. Is cytology may be all right for cervical cytology, where there are free-flowing cells sitting around there. But otherwise, correlation with dysplasia in histology and cytology is only 35%. Here we find another statement coming out of hospital, and these statements are coming out regularly. It's a public crisis. The crisis has been sitting with us when we had 30 dental schools, and now the crisis is coming when with 350 dental schools. If dental profession is supposed to be involved in that, then one can say there are 350 dental schools around, I think, plus medical institution, plus so and so. So it's a staggering sentence to indicate that there's a public health crisis. But that's why I said, are we done? Unless we do something about it, I mean, we may not be in the right frame of mind to make statements like for the patient side. But one more thing I don't, patient never come late. Patient do go to some doctor, maybe Unani, Ayurvedic, homeopathy, who doesn't understand what he's talking about. But I can't keep blaming a patient every time the patient comes late. In a hospital record, you can say that he's not been to the hospital. But blaming the patient all the time, that one of the failure of this is because of the patient coming late, is passing the buck. Loss to nation. I mean, they just are possible. Now, how does this thing happen? People, pan masala, it was an unknown habit. So advertising has created demand where none existed. The power of the ad word. Pan parag and all that thing. I've used it, pan parag. And these are the kind of advertisement that appeals to, naturally is going to appeal to the crowd who doesn't understand the value of that. And here you have I'm just showing one side, a corporate guys are coming into picture. And here you can see the advert, it says Zenith. And what about our word? Here our word is our silence is at its peak. Now this is a combination of two things. Their word is at its zenith. They are talking at the highest level, and we are silent at the peak level. So naturally these things are going on. And as Prasun Joshi was a chairman of the advertising should resonate with law, meaning some kind of a social commitment must be there. And again, you find that the quitting habit of tobacco is very limited, but the pickup rate of tobacco is very high. And therefore, one can say, okay, they are hosted to its own nature. Like when somebody doesn't give the habit, you realize okay, for him, the necessity has become a way of life. Habit has become a necessity. You can't argue with it. And secondly, if we don't do anything right now, the present that we have, the present shall become a future. So that has been happening since the days when oral cancer is coming up. The present state level of the high level of oral cancer is becoming a future of high level of oral cancer. So eventually the present becomes a future, and where we all are in the picture. So therefore we are also hosted to our nature that we possibly have not done sufficiently for these things. Here is there's a slide given to me by Dr. Hazare, courtesy. You can see that submucous fibrosis is happening at that stage. I won't go. Submucous fibrosis global is the location of cancer. So all the cancers that can occur anywhere in fibrosis. I'm just showing you, I'm going running through a few slides for you to realize that fibrosis and cancer together. And this is another paradox, which the cause and effect is associated absolute. You may not get a fibrosis done at all, but still simple observation of staying away from eating a that might lead to a serious consequences of fibrosis happening in your life. But who shall tell this to our population? They themselves are not going to understand because they don't have an understanding of the subject. Neither they understand because they're so stuck with their own problems in life. These are the simple measures of areca chewing gives them a tranquility, peace of mind. And therefore you can't blame them. And the gap between the occurring habit and cancer is going to be longer and longer. So you cannot, so initial pleasures of life landing in the pain at a later stage is something that you and I can understand, but nobody else can understand really. In our own life, the initial pleasures are there, but the pain is there eventually. And philosophically speaking, all the external pleasures of life have an expiry date. So reversibility is the key thing. Again, I just have to touch this point because after what we found cancer occurring without habits, I mean, here you find that we have been, being observed, cancer occurring in population with no habits. And this is one paper that I've seen it number of times. Nobody has reproduced the paper, whether the histories are correct or not. And I'm just quoting that figure. It's a paper done in Hubli by D.S. Aruna. And you know what it says? That 25% of the patients had no risk habits. Now, whether you like it or not, this is printed. So you have to accept the fact that today the cancers in the mouth can occur without habits. So you're bringing on another road of challenge till you disprove it, prove it, or do something about it. But today it has gained into ground in the literature that you can get cancer without habit, which is fair and fine. But you have to understand that this is a reality figures, or you have to understand this by reconfirming it. This is published in Asia Pacific Journal. I'm just letting you know these figures for you to understand, because I still feel that eventually it's a precancer that story should work. So shift of oral cancer, it's a penny drop moment for years and years, but still it's still dropped only, not gone into action. Why I said the slogan should be prevent precancer, it will spare you irreversible cancer, like fait accompli cancer. It's the easiest thing to do. You can identify the causality. It's a reversible, readily recognizing pathology. You don't require any fancy thing to do. And it's permitting practicable prevention. What else you want in your life? As Neil Johnson wrote, cancer buccal mucosa, they are gifted to have cancer in wrong way, but buccal mucosa is the one that allows you to gain access to some preventive measures. This is the Latin for we all use over our primary oath, primum non nocere. There are no limits to how much we know, but there are strict limits to how much one can or should do. And that's the reason I feel come back again to the same story of precancer. So we may be overtrained for some basic pathology, which is fair. But when we come to the basic track of dealing with the cancer on the root level, the ground root level, we need to train our people to do this at that level. Doing our technological advances in the molecular level is fair and fine up to a point. But if you're really looking at the public health measures, then you need to be something different. So we are overtrained and undertrained, both. This is after having journey from 66, am I thinking, have I got a flippant objective? The objective that doesn't merit attention, or the objective that needs consideration? This journey for oral cancer started in 1966, still going on. And therefore, I spoke in one of the meetings of it's a kind of the Hindi film song, एक छोटी सी गुड़िया की लंबी कहानी, कहाँ करूँ शुरू और कहाँ करूँ खत्म. It has started, not over. And this is one of the pictures of people who helped us out to do the job. And this is a picture done in the initial years at TIFA. And grateful to them. Gupta, Bhosle, L.D. Singh was a senior epidemiologist. There are many, many people who have contributed. This journey has been there with so many people. Everybody has helped out. Our technicians were biopsies, and mainly there were no artifact pathology, everything. If you look at it, large number of people have helped us to do this journey. I'm just representing a part of the journey, part of them, and presenting this observation of a journey committed by a large number of people for a number of years and coming out with valiant observations and conclusions. For it to make a difference or impact, I am not sure. But my job is an action, and therefore I did whatever we have to do. And therefore there was no simple word like thank you. I have used the Sanskrit close of Kritagna to these people who have worked with us, all our team members. Grateful and obliged to you all in our team for the deeds performed in our Kritagna. That slogan is very Sanskrit taken. Bhavata Sarvana Prati Aham Kritagna Asmi. And that's why I thank you all for listening to me quietly, peacefully. And I hope I enjoyed delivering things. And I hope you also enjoyed listening to it. Thank you, Dr. Nakmal. Thank you for your team and everybody. Thanks a lot.
Yeah, thank you so much. It was indeed a enlightening lecture, sir. And old is gold. It was a masterpiece, I must tell, and a lot of good comments about your lecture. And I just want to tell that a good teacher is like a candle. It burns itself to light the way for others, and that is the thing sir has done. As a good speaker, he not only delivers word, but it has inspired minds, stirs emotions, and leaves a lasting impact with their wisdom and clarity. So, before giving the final concluding remarks, sir, a few questions are there. Uh, would like to answer those. Like Dr. Pran Avasti, and even I have this question in my mind, that now what is the way forward? How the dental specialties convince the lawmakers to be overactive to curb this problem? Or if I add my thing, like what is your practical strategy? Like how we should go ahead about it to curb this problem?
Are you asking me?
Yes, sir.
See, basically, I'm not. The journey began in 1965, and that too in that difficult circumstance where dentistry was not even considered important by anybody in the world. And the intent must come in first. When the intent is there, the action will follow. And to be very honest with you, or if it's a curriculum that we are not being taught, or the people dental profession, you have a place at dental profession where dental profession can get involved, or in oral pathology, you can start a small center. I'll tell you one thing. Anybody who wants to do any work, serious work, there is a never dearth of money.
Yes.
You must have your protocol straight. You must know what you wish to do. Because there's a, if you look at the publication, the large number of publications come up which may have no value or no value. So there is no money, but somebody should sit down and want to do it. And I know in these days and time to do academic research with financial benefits on all that thing is something which everybody has to think about it. But intent must come and group of people, the solutions will emerge. I don't know the nitty-gritty of the education at this moment. I'm not in the field of education, so therefore I can't comment on it. But when we were there, I knew what can be done and what cannot be done. Now, I'm not exactly an outsider or insider, but you all know where the shoe hurts or shoe pinches. So you can figure it out for themselves and then see.
Yes, sir.
But intent must be positive. And I'll tell you one thing. You asked me action. There are two things that I have learned over a period of years that Rajgopalachari had said when he had to spoke on Indian culture, the ethos of Indian culture. There's only one thing when he summed up: consideration for others. Another thing, an attitude of gratitude. We have been given many things by nature or otherwise. We need time for us to give back.
Yes.
So figure it out and you'll find out the solution. The roads will open up.
Totally, sir. Agreed. Very
I mean,
inspiring
right now
thing.
you can
And
just can't sit
this,
there and find out exactly, but the intent must come through, action will follow.
okay, sir. And already, sir, this pan masala thing is not only the cancer thing is there, but it's a burden on our economy also. Because around for cleaning, like some days back, we were discussing that around 12,000 crore rupees are spent only on the cleaning of the pan masala spitting, be it at railway stations or other places. And these have actually, the death numbers have crossed, if we combine the deaths which have happened in both the world wars. If I'm not wrong, sir, at one of the conferences, this was a statement that the pan masala and the oral cancer which has caused oral cancer has actually reached that level. And yes, it's a for business. Yeah, they say that it is good because even I don't want to take the name. The pan masala companies, they only are opening up the cancer hospitals. So eat their pan masala and then your cancer will be treated there. Anyway, sir, the next question is by Dr. Abhishek Badranna, sir. He's telling that excellent talk, and but he's saying that Areca nut is considered as a goddess Lakshmi in our culture for centuries, and it is given as tambula, a gift of honor to your guests. And he feels that the quick processing or industrialization of Areca nut may lead it to a class 1 carcinogen. So previously, areca nut was sun dried and slowly processed along with the natural dyes. So there should be, sir, in your experience or your comments, like any inspection for pan masala industry?
See, areca nut, we were using naturally occurring areca nut all the time. And it has there in with thousands of years we have been using areca nut. There is no recording of a fibrosis in that sense. Dr. Hazare has done that book on fibrosis. He is not able to get any connection except calling a vidari, which is not fibrosis. So having understood if areca nut is a naturally occurring substance when it was used, we didn't have any situation like fibrosis happening. Till 1966, there was no commercial product of areca nut. We had pan masala with the areca nut. So till 1966, fibrosis in that sense was not exactly a problem of ways to reckon with. But we need to go to the basic. Areca nut became carcinogen in 1985 by Indian at the meeting in Paris. They classified areca nut as a carcinogen. Now that is, I have not been, I mean, I'm still not 100% on that ground of areca nut carcinogen. It's a Taiwan and Papua New Guinea. You have a large number of in Papua New Guinea, you have highlands and lowlands. And you have a areca nut growing in a different manner. And they also think the areca nut is a bit different between the two lands, highlands and lowlands. Same thing in Taiwan, South Korea, and all the things. Areca nut is a very important product. But in 1985, they classified areca nut as a carcinogen 1. Now, as I said, for me, for fibrosis, areca nut is essential. And for cancer, tobacco may be essential. So, areca nut be apart, I accept areca nut has never given any issue of records in any other areas of our in literature. So from that angle, if you want to go deeper part, you have to find out whether this areca nut that is being produced naturally occurring and has also been genetically modified. But if somebody wants to use areca nut, it's better they use only naturally areca nut and not commercially manufactured pan masala areca nut. That's the only thing that I can suggest in this way because we don't have the understanding of the today's areca nut. So that's the only observation I can make in the absence of any further understanding of the.
Perfect, sir. And there are another lot of appreciation messages by Dr. Vinay Hazare sir, Dr. Bhadranna sir, Dr. Sharda ma'am, and many other people, Dr. Guru Raj. Uh, I think there is no further questions. Yeah, only so what message you would okay, Professor Jose has he's saying yeah, thank you so much for the for sharing your historic and valuable perspectives. Tobacco industry is well known for its worldwide enormous profits. Any idea what the financial extent is of the areca nut industry, or it is mixed with the tobacco gutka industry, especially in India, Asia, or East Africa? Professor Jose is asking this question.
No, I didn't get the question.
So the question is, like, any idea what is the extent of finances which is involved with the areca nut industry, or when it is mixed with tobacco or gutka industry, especially in India, Asia, or East Africa?
My answer is simple. As far as till for years together, submucous fibrosis is not even considered as a disease pathology. And that time, all the areca nut that was coming out is a naturally occurring product. Now, this is change. So, therefore, to ask that question, but one thing is certain, even today, naturally occurring areca nut may not lead to serious consequences as compared to these pan masalas. It is pan masala and mawa has changed the entire game of fibrosis. But question still remains. Areca nut today, you have to analyze it yourself to find out whether there is any difficulty change. Like if you go to the content of pan masala, there are many contents are there. And it requires a little deeper understanding of the fact. But areca nut leading to fibrosis is acceptable, but areca nut leading to cancer, there are cases reported so far, but I am not aware of it, so I can't comment on the subject. But as of now, the habit that is being spoken about it today, it is irrespective of how much importance you give to areca nut, or you have to, in today's understanding of the knowledge which I see, that one must stay away from both areca nut and tobacco without undergoing any further under discussion. We may not find the reason really.
Yes, sir.
It's safer to stay away from these two, areca nut and tobacco.
Anyways, the answer has been shared also by Dr. Badranna sir. Now I request Mandana ma'am. Dr. Mandana ma'am, are you there?
Yes, very much so.
Yes.
Yes.
As we conclude this enlightening session, I would like to extend my heartfelt gratitude to our distinguished oral pathology stalwart, Dr. Dinesh Daftari sir, for sharing his profound insights and decades of expertise with us. His passion, vision, and unparalleled contributions to the field of oral pathology continue to be the source of inspiration for all of us. On behalf of POPMA, which is Practicing Oral Pathologists and Microbiologists Association, I again sincerely thank everybody who have attended this talk for your presence and participation. Now, ma'am, please do the honors because
What do you want me to do? Take a picture? I already did.
no, I have shared it, but we on that mode, it is you do the honors of giving this token of
Okay.
appreciation,
Okay.
felicitation to sir.
Sir, thank you so much on behalf of POPMA for this wonderful talk and for sharing insights of many years. And it is, as always, been great to hear you. Please accept this small token of appreciation on behalf of POPMA. Thank you, sir.
I must thank you people to be there, and it was nice. That's all. I participated with all the oral pathologists. It's always a pleasure to be with oral pathologists. And I wish you all the best all over for your career and otherwise.
Thank you, sir. Thank you so
Thank
much.
you, sir. Thank you so much.
Thank you, Dr. Nagpal, and thank you.
Thank you, sir. Thank you.
When you want to
everybody.
ask everyone to put on their cameras?
Yes, yes. I request everyone, we can have a group photograph if
Interestingly hearing it. You enjoyed it?
Hello, Azhar sir.
Hi, sir.
Bye,
So your mic
bye.
is on mute.
Bye. Are
Sir, wait for a minute. Sir, we are taking a picture.
Are you taking a picture? Okay, take it.
Yes, yes. Please wait for.
No, I'm waiting here. What do you like?
Yes,
like the
done.
Yes.
They're taking a picture.
Hi, Sharda ma'am is also there. She's there.
Again, I'll take one more.
She knows she is there. Taking a screenshot.
Yes.
Okay.
Done.
Thank you so much.
Oh, hello. Let me take one more quickly. Yes. And 1 second, everyone. 1 second. I have to keep saving them in between, otherwise I will lose them. So that's why it takes a minute. Okay. Smile, everyone. Say
Thank you very
cheese
much.
or
Good to see you, George Hill.
Yes.
done.
Is he, Dr. Professor Hill is coming to India or not? Huh, Akbar?
I will invite him, sir.
Invite, yeah.
Yes.
You need good guys. Anyway, thank you very much.
Thank you, sir.
Thanks a lot.
Thank you. It was
Thank
pleasure,
you.
sir, to have you
Thank
all
you.
with us.
Thank you.
Thank you, everyone. Thank you, everyone. Okay.
Thank you.
Bye.
Bye.